Hi, my name is Micah Long. I'm an anesthesia intensivist, which has led me down many a dark airway path. I give a lecture on this pretty repeatedly about the challenges of emergency intubation, and I want to start today with just talking about the risks of emergency intubation. The easiest way to think about the risk of emergency intubation is to think about the one that goes wrong. Imagine you're a newly minted CA1, you're taking airway call, and by dumb luck, 2 airways get called at once. So you get picked to go to the less urgent one, and you're going alone. Your help will be behind you, but it'll be a few minutes. And when you get there, you see the patient, and they're working very hard to breathe. They're on high-flow nasal cannula, 50 liters a minute at 100% FiO2, and the respiratory rate is like 1,000, 2, 1,000, 3. The SAT is 83 or 84%. They look ashen. They maybe look cyanotic. You try to get your drugs ready and get your PPE on, but your gloves, your hands are sweaty. The gloves aren't sliding on right. People are staring at you. It's kind of quiet. You're trying to talk to the patient while you're setting up all your things, and the patient keeps sliding down the bed because they're agitated. You decide, forget it. I just have to go to sleep. You grab your Trident 2 etomidate and succinylcholine. You go to sleep, you grab your VL number 3, your 8.0 endotracheal tube is right nearby. Patient goes to sleep. Slide down a little bit, you finally get some nurses to help you tug them up as the SAT drops, and it drops all the way down, 60, 55, 50. You expected this, you knew they were on a lot. Fasciculations start to fade and you get ready. You throw the glide scope in, it's covered in mucus. You can't see anything, have to pull out, trying to clear it. You're suctioning it, the heart rate starts to drop. 110, 100, 50. You start hearing the dropping heart rate. You start to bag mask, hopefully to stop the arrest. It seems like you're moving air, but it's not super easy. You grab the oral airway, your hands are all stuck to the paper. You didn't take it out first, the packaging's hard. You finally do a nervous bag mask attempt. Blood pressure pops up 70 over 40. You grab the phenylephrine. Oh wait, the phenylephrine's stuck in the backpack. The backpack's on the floor. You assign somebody to find the phenylephrine. As you just figure out, you'll just try to put the tube in. You finally look with the VL the second time. You see the airway. You drop an 8.0 in. Get stuck on the vocal cords a little bit. You thread it over. You finally feel like you can take a breath, and that's when the pulse ox stops. The nurse announces she can't feel a pulse. We know that airway experiences like this happen probably more than we like to admit. Of course, all of us go through some hard ones, and we go through a lot of easy ones. When you look at big meta-analyses and studies that look at how risky intubation is, it turns out that intubation outside the operating room is very risky. Big studies look at the incidence of difficult intubation being 10 to 100 times more often in the unit environment versus the operating room. Severe hypoxia and hypotension both individually occurring in at least a quarter of patients. Aspiration, 1 in 50 to 1 in 10. Cardiac arrest in the biggest trial is 3%. 2% in the second biggest trial. Most trials somewhere in that 1 to 3% range. Not arresting before you put the tube in, but arresting around your intubation. And we know that there are lots of risks for who's not going to do well, who might be challenging to intubate, but we know that complications are really frequent. You see the Makocha score on the right. This is put out by a French group that does fantastic airway research, and they have at least one complication over 60% of the time when you are manipulating the airway repeatedly. Big meta-analyses looking at airway complications, again, show an insane rate of airway complications. This is everything put together, but it's important to remember just how often bad things happen when you are intubating somebody. And it's important to remember not only do bad things happen often, but as things are going wrong, things tend to spiral out of control. And this goes both the procedural to the physiologic route, right? You're having trouble intubating, and then they get desat, and then they get hypercarbic, and then their blood pressure drops, and then they get to the peri-arrest window. But it also happens in the other direction, where the physiology challenges make it harder to put the tube in. And I always think about this as the showing up to an airway and trying to manage norepi, epi pushes, propofol, whether your propofol wore off, positioning on the bed, all while you're trying to get the airway. There's just so much happens that's happening very quickly in an intubation that when something starts to go wrong, it starts to lead to other problems. And we see this by looking at first pass success, where the more you mess around with the airway, the more things go terribly. And it's not just anatomic things like dental injury and aspiration and hypoxia. It's things like physiology going wrong, because as your attention is focused on a difficult intubation, you may not remember that your propofol is about to wear off, or that your succinylcholine is actually starting to wear off. And we see this in every time it's looked at. There's a more recent one that looks at cardiac collapse with increased attempts, severe hypoxia, aspiration, and dental injury. All of these things go wrong the more you mess with the airway. The difficulty, again, is not just technical skill. There's a lot of technical skill there, but there's technical skill of a whole bunch of different things that you might need to do. You need to be able to DL, you need to VL, you need to be able to push the tube in when the angle is funny and know how to thread it. Maybe put a bougie down, put in an LMA. Maybe it's an LMA of a unique brand you haven't used before. Maybe the patient's anatomy is unique. That difficulty of the technical procedure itself is confounded when you have to pick the algorithm that'll work for you, right? Do you awake first? Do you rescue with a bronchoscope or a VL? Do you drop an LMA immediately, or do you wait and try other things? And in the course of all of that, your physiology changes and it's more challenging in the ICU environment. Patients aren't going to tolerate the brief hypoxia. It's really rare that you're able to adequately pre-oxygenate an ICU patient. And your physical space is way worse. Here in the operating environment, we've got space galore and tons of airway experts all near you. If you ask for something, you can get it. The beds are narrow. It can get to you. That doesn't happen in the ICU environment. And so, emergency intubation is a very high-risk procedure. It should be approached in a very prepared way. And that means the day of the procedure, when it's happening, you come in as prepared as possible, having worked through your bag. You know where your supplies are. Everything's in your pockets or nearby. But you should also be preparing before you are on call for that difficult airway. You should be scared of these because things go wrong with astonishing frequency. You should always have help. You should be prepared and work through these situations on your own or with a team before you enter the situation where you could hurt someone by doing it wrong.